Thank you, everyone. Welcome to Renegade Research Roundtable. If this is your first time with us, thank you for joining us. And of course, thank you for those of us who are joining us regularly. I am Isabel. I'm the CEO of our organization, and we are a patient and caregiver-led, decentralized 501c3 nonprofit organization. We focus on complex, multi-system chronic conditions such as ME/CFS and long COVID. Within this, we have 3 areas of focus: research that's agile and patient-centered, education to increase the number of clinicians treating us, and practical advocacy around barriers to care. Our work is made possible by our wonderful team of volunteers who move the wheels of our organization. Most of us have a personal interest in advancing research and care of these conditions. To stay in touch with us and hear about our upcoming events, please subscribe to our newsletter and follow us on social media. We will be posting the links to those throughout the presentation for you to be able to have. Our work also depends on donations of all sizes. You can help fund our work by donating to our funding campaign and also by sharing our campaign with others who can donate, and we will be posting those as well. We have more great and informative roundtables coming up. Visit the event page of our website, renegaderesearch.org, and I'll pass it off to Tess to introduce today's topic and today's speakers.
Thank you. So I'm Tess Falor, founder of Renegade Research. And Renegade Research is a nonprofit, like Isabel said, but it started off as just a hashtag on Twitter of us talking about this idea of patient-led projects. And the acid test was actually the second one that came together after our other project, Remission Biome. And so today we're going to be talking about the acid test. We'll start off with Ciara Wright, who will give you a bit of the background of how it came together and intro the project. And then Todd Davenport will take over and give some of the results, some of the science behind it. So we'll start with Ciara. Ciara Wright is a scientist and a nutritional therapist practicing functional medicine. She obtained her PhD in molecular and cellular biology and worked postdoctorally in diverse research fields such as stem cell science, gene therapy, microbiology, and immunology. She runs Positive Nutrition, which has 2 nutrition clinics in Ireland, though mainly serving patients online now. She has had long COVID for 3 years, but is recovering with anticoagulant therapy and treatment for a reactivated Bartonella infection. She is delighted to be in a position now to help other patients. So I will pass it off to Ciara to give us some of the intro of the acid test project.
Thank you. You all get an F for pronouncing my name. It's Ciara.
I knew that. I remember that.
I know. Don't worry, I know it's tough one. So I just kind of went on a little back in time journey. It was actually quite fun going back through Twitter of 2023 and how we all got started. And I really kind of, re-remembered a few things, and I have a few learnings that I myself took away from even just doing this short journey. But this is our little team. So obviously Tess and Isabel, who just introduced us. Myself, Alice, who I didn't know whether she wanted to remain anonymous, so I've just left it as that. The lovely Todd, who we'll be hearing from shortly. So he's going to talk us through some of the science and the research and the results. Harriet, who I see here, Naomi Harvey, with a special mention of Loki, who's in appearance there, and David Puccino looking great there with his black dot. So this was our team, and I was trying to find out exactly how it all got started. And it was back when Remission Biome was starting their initial gut experiments, and we were talking about lactate production in the gut. And they were going to use a lactate monitor in their experiment to see if there was a change in lactate levels, pre and post antibiotics, or pre and post the intervention. But their lactate monitor was like $600. So that was kind of out for me until I found, like random Googling, found this €20 machine that a company was selling in the UK. So I decided to order it, got stuck in customs for like 2 months, so I had to wait for it. And in the interim, lactate just kind of started having a bit of a moment where people were talking about it. A few people had the Edge lactate monitor and were starting to measure and talk about it online. And then Court Johnson published a Health Rising article on lactate and how it might be coming from the gut or the metabolism. And then on one of our many, many Twitter chats, myself and Harriet Carroll were just like, hey, I just bought this, this cheap one. And she was like, great, I do too. And then a whole bunch of other people just jumped on board. And somebody today on Twitter described it as this snowball effect. And everybody just wanted in and wanted to participate. And that was one of the real take-homes that I kind of remembered from going back through all of these tweets, was how keen everybody was to partake, not just for themselves, but to be part of the science. So that level of patient involvement, I want to help, I want to be part of the data set, I want to contribute to the science. If this is going to be like a biomarker, nobody knew where it was going to end, right? Is it going to be a biomarker? Is it going to lead to an intervention? Who knows? But I want to take part. And especially people who were either housebound or bedbound, who might have never been considered partaking in trials, might have never been able to partake in trials, or even trials being designed with them in mind. So this was something that they could do from their own home. So it was really, really exciting. And I can't actually believe it, going back through all of the tweets, that this was the 14th of April, where we were just like, yeah, sure, let's do this. And within one day, we had started chatting and decided, well, if so many people are going to do this, we should really do it as a study. We should really be able to report these or collate the results and publish it. And it was myself, I think Naomi and Harriet, that were like, let's definitely do this. And then by the 16th of April, we had our private group chat up, where we were designing, a questionnaire. It's Naomi Harvey, and Harry is not my area of expertise. I'm the lagging behind here. But in terms of designing a proper questionnaire, Naomi is a GDPR expert. So how we were going to gather this data and have it publishable. So that's where we started going on about, well, we would really like to have IRB approval. Who could we bring in on this? And kindly Todd Davenport and David Puccino kind of joined the team at that stage. And Todd had a pre-validated PEM questionnaire that we could utilize, and it all started to come together, but literally within days. So it was crazy to think back on all of that, actually. And then because so many people wanted in on it, and GlucoRx were throwing away lactate strips that were about to go out of date, so they were giving 2 packets of lactate tests free with every 20 euro monitor. So it was for nothing, really. So we decided to jump on board, and we all pivoted and became like an international logistics team, and started shipping monitors and test strips all around the world. And there's another honorable appearance of Loki. And I want to say a big thanks at this stage to every single person who participated in the logistics here, because it wasn't just everybody that's on the team, even though they definitely bore the brunt of it, but there's so many family members. This is my sister's forearm who is posting these strips out for me. Husbands and partners and carers and everybody that got involved in this. Or we would ship a group of monitors to one person in America or Canada or whatever, and then they would ship it up further on locally. So many people got involved. It was really, really enthusiastic. And I think, like I said, that was just such an important take home about the level of patient involvement. But the second big, memory I had about this was once the results started rolling in. So people were posting their at-home lactate tests on Twitter, of course. And this is what I would call, anecdotal information, right? So Todd is going to talk more about the basis of this study and the science and all of this, but what we were kind of going off was this and other studies that showed that there was elevated lactate in some people with ME/CFS. And we were kind of saying, right, well, anything above 2, we will class as, an elevated lactate. So you guys that are out there testing, below 2 is kind of normal. Anything above 2 is something to be thinking about. And as the results came in, we were seeing huge levels of lactate in some people. And again, this is what I'd say, this is anecdotal information. I mean, this is a great example of bias, okay? So Todd will show us, the true data, put through the statistics and everything. But what I remembered from this was how validating it was for patients who had never had an abnormal test result, whose doctors were saying, well, I can't find anything wrong with you, so off you go home, I can't do anything. And all of a sudden there was a test available to them in their own hands, literally, that could show, I'm not imagining this, there's definitely something wrong. And actually, if you were in, an ED or an A&E department with a lactate of 9.1, there'd probably be bells going off and alarms and doctors running towards you. Something that somebody wanted to do something about. So that was quite exciting as well at the time. And then, of course, us being patients who were trying to fix our own problems. And again, this reminded me from Kat's tweet here, where they were like, so now what? Like, how do we fix this problem? What does it mean? And what can we do about it? So in true, patient scientist format, we all went out and tried to figure out, like, why is pyruvate converting to lactate and not continuing on into, and again, Todd will talk a bit more about the science behind this, but what's happening, literally getting out the pen and paper and finding out how can we get into this system and try and fix it for ourselves. So I remembered that I think about like 8 or 10 of us ordered DCA powder from some random lab in Germany, and it came as a powder, and I think it was about 80 euros. So it was kind of expensive. So we split it. So we were literally posting parcels of white powder like across Europe to each other and trying out DCA, trying out things like high dose thymine, alpha-lipoic acid. I got quite into the amino acid end of things. Anybody who followed me knows that I took AXA 1125 for quite a long time. And this is the part that reminded me that, we're definitely looking for biomarkers. We're looking for, underlying pathologies. And again, Todd is going to talk more about that, but we're also looking for interventions. And while randomized control trials are obviously ideal, and that's what we'd like, and that's what, that's, optimal, it's also going to take years upon years. And is there something I can take right now that might be able to nudge the needle in the right direction for me? So this was my take home, that I remembered that at the time I really wanted to write a review on potential interventions, but sure, I didn't have the energy and I wasn't well enough. But now it's kind of brought it back to me that I would really like to kind of commit to doing that now, to see if, if there is usable information already out there that people with high lactate could utilize. Because some people did use interventions that helped them. And I don't know if many people are following Ivona, and it's certainly not the only intervention that she has used, but she has found that lactate and managing her lactate was a large part of her, long COVID puzzle. She did IV ALA. She continues to manage her lactate. And it turned out to be really important for her. Naomi Harvey did her own little kind of self-experiment here with magnesium and found that just for her, not for everybody, but for her, magnesium fairly reliably lowered her morning lactate levels and her postprandial levels. So that's another learning there. And then it was very coincidental, but even at the same time, Vicky van der Tocht brought out her hypothesis paper about acid-base balance, and that she was tweeting all about how she used an alkaline diet to kind of counteract the acidity from elevated lactate. And she was talking about, breath work and electrolytes and all of that kind of thing. So there's definitely loads and loads more information that I feel could be kind of drilled into. And it took going back in time and actually preparing for this webinar for me to remember that all of that is still kind of waiting to be done. Anyway, so I'm going to pass you over to Todd, and I had said to Tess that I would give his official introduction, other than the fact that I know him to be an absolute gentleman, but I don't have it because I was late to join the webinar. So Tess, I don't suppose you have that right there in front of you and could read it out for Todd, do you?
I do have it.
Thanks.
Okay, yeah, I'll read it. So Todd Davenport is professor and chair in the Department of Physical Therapy at the University of the Pacific in Stockton, California. He earned bachelor's degrees in psychology and exercise science and sports medicine from Willamette University, doctor of physical therapy, the University of Southern California, master of public health from the University of California at Berkeley, and doctor of philosophy in sport health and exercise science from the University of Portsmouth. Dr. Davenport is a scientific advisor to the Workwell Foundation and chair of Long COVID Physio. His research involves the systems level physiology and clinical recognition of ME and ME-like conditions. So that's the official one, but Ciara did say he is a gentleman. I just have to say he is one of the best allies we have for patients with these conditions. I just really appreciate everything that he does on Twitter, standing up for patients and sharing the science and everything. And thank you for getting involved in this study, Todd, helping us out.
Gosh, thank you for having me. And now I feel like logging off after that introduction. That was way too kind. So thank you for that. But hopefully I continue to earn that. I guess that's a moment-to-moment thing, and we'll all find that out together. As everyone mentioned, I'm Todd. I really appreciate Dr. Wright's overview of how we got here, because I think that's critical. I'm a member of this team who does not live with ME, and I do not live with long COVID. I've got my own chronic conditions, but ME and long COVID are not one of them. And so I have spent the past 20 years working hard to learn from patients. And this is another opportunity for me to learn from patients. And I have learned so much from this project, as I've learned from previous and ongoing collaborations, and looking forward to working with this group and with you all in the future. So this study was called the ACID test. It was hatched on social media. Social media is a nightmare. Twitter is a grease fire, but it's not bad for everything, I suppose, because you can actually do some reasonable science with it. And I was sort of watching the dialogue taking place about lactate, because we started talking about lactate in ME/CFS before the SARS-CoV-2 pandemic. And it just reminded me of some of the conversations that we started in some cases about 20 years ago, when we started identifying that people had an early onset of anaerobic metabolism, and that was associated with lowering what we call the lactate threshold, meaning that people were producing more lactate earlier in exercise tests. So I got super interested and reached out to Tess and to Isabel, and was just graciously invited into the fold. And just want to thank everyone for that opportunity and for the chance to address you today. So with that, here are my potential conflicts of interest. You can decide if they're conflicts. These are the people I hang out with who make me smarter. I am professor and chair at University of the Pacific. I'm an unpaid research consultant with the Workwell Foundation. I'm also a volunteer chair with Long COVID Physio, and I'm speaking on behalf of myself and not these folks, unless they want to post something on social media because they're happy with it. Sometimes that happens. I also want to do my own acknowledgement of our ACID test team. The researchers that you saw, we all kind of look like our avatars. I could have dressed like my avatar, I suppose, but neglected to do that. But just a mixture of folks with lived experience, with ME, with long COVID, scientists who do not live with the condition, with the patients leading, and for the purposes that Isabel mentioned at the outset of doing better science faster to find cures. I also want to acknowledge, excuse me, the 132 generous people with ME or an ME subtype of another condition, and most commonly long COVID, from a range of functional impairments, 20 different countries, contributing each about an average of 5 different lactate measurements. So stuck themselves more than once for science. And I just want to acknowledge that our acid testers are an important part of our team, and to acknowledge you and thank you. And if you didn't get to it, didn't get a monitor, didn't think of it before the survey closed, all good. You're part of the team as well. So I'm never sure who comes to these. I know that there's Renegade Research draws a very engaged audience of clinicians and researchers, but also patients. And so I tend not to assume a lot of prior knowledge. And so if that's insulting, I apologize. Hopefully you will find it helpful. I've also tried to kind of keep my slide backgrounds. My slides are a little busy, I confess, but I tried to keep my backgrounds as least distracting as possible. I will try and speak as clearly as I can. So if you need to close your eyes and listen instead of look at the slides, anything to improve your ability to engage cognitively. And of course, we're recording this session for later. Normally your muscle during activity uses different types of fuels to function. So when you first start to exercise or first start to move your body, the first thing to go, the first substrate to go is whatever adenosine triphosphate is hanging out in the skeletal muscle, whatever glucose is hanging out in the skeletal muscle. So you burn those short-term reserves within about the first minute of activity. And then, after that first couple of minutes or so, you start to kick in the very powerful what we call Krebs cycle, which is making all the clinicians and the researchers shudder a little bit, because it's the first thing we learn in our training, and it's the first thing we try to forget because it's so complicated. And it just so happens that that's what I've spent most of my career trying to understand. Its scientific name, its full name is oxidative phosphorylation. Oxidative because it uses oxygen to burn fats and sugars. And it tends to create an abundance of this ATP, which is the energy molecule. Now, the downside to this is that it creates what's called lactate, which is the conjugate base to lactic acid, which is what people commonly will know, but we measure it as lactate. And over time, this lactate, as well as oxygen-free radicals that get sort of generated as a product of this process, defeat oxidative phosphorylation. So start to kind of gum up the works, so to speak. And so now you don't have ATP coming from oxidative phosphorylation. So that energy system starts to drop off in its contribution. And towards very heavy exercise, or towards the end, is what's called the lactic acid cycle, sometimes called the Cori cycle, where the body it takes lactate molecules and tries to make essentially ATP out of them. And it's a very inefficient process, and it actually results in a net loss of energy molecules. And so it is literally the thing that you do to just kind of get past the kind of the last stage of exercise, to get up that last step, to take a few more steps away from that, sprinting steps away from that saber-toothed tiger to avoid being eaten. And so it is literally the end. And I'll point out that we spend most of our life in this sort of area between the phosphocreatine cycle and oxidative phosphorylation. We sort of live here. This is where most of our functional activities are performed. We do not like to necessarily be in the lactic acid cycle as much as we possibly can. It's uncomfortable. Muscles burn. Gastric contents tend not to stay gastric. There's a reason we have a bucket in the CPET lab. And so there's all kinds of unpleasant things that happen here when we start trying to metabolize lactate. And people who live with ME can tell you all about them. So in ME/CFS, what we found through a variety of different methods is that oxidative phosphorylation does not work properly. And so, we think that there's still the phosphocreatine cycle, so still the ability to metabolize whatever ATP and glucose is there in the and the skeletal muscle already. But that the oxidative metabolism doesn't work in the post-exertional state, because on an exercise test, a 2-day cardiopulmonary exercise test, if you exercise test someone with ME on one day, on the second day, they will have an early onset of clues related to the lactic acid cycle. And that happens earlier in the exercise test on the second day during PEM. And it happens at a lower workload. So you can see that this triangle is now, this of exercise intensity is now smaller, because essentially this is what is physiologically possible. And so over here to the right, we have the plug-in hybrid car. I didn't choose Tesla for reasons. And if you know anything about a plug-in hybrid car, and I know a little bit, so I'm already out over the skis of my expertise, there's a couple of different fuel sources. The first is the battery, and the battery is very good for lower intensity types of activities, stop and go traffic, and so forth. And the gas motor is really good for freeway speeds, higher intensity activities, going up and down hills, hauling people in gear. And so there's essentially a switch within the car that switches from the gas, the battery, to the gas motor. And the gas motor also charges the battery. So the analogy here in ME and ME-like conditions is we think the gas motor in the plug-in hybrid car is broken. And what you lose is the ability to do sort of the more higher intensity activities. And by higher intensity, I mean just sort of activities of daily living, not totally unusual stuff. And it results in an over-reliance on the battery to do these types of things. In addition, because the gas motor is broken, you lose the ability to charge the battery. And if you can't charge the battery, obviously, then you're running the risk of depleting the battery and breaking down at the side of the road, which by analogy would be a crash. And so that's sort of a quick course in bioenergetics, and hopefully that helps set the stage for what it is that we're going to talk about. Notice the key word lactate. So if you spend more time in anaerobic metabolism, which we think people with ME do based on their responses to acute exercise, then they should have an increase in lactate concentrations in the blood, and we should be able to measure that. And so that's sort of where this idea came from. So again, if there's this dysfunctional aerobic energy system, you'll spend more time in anaerobic metabolism, you'll increase the concentration of accumulated lactate in the blood, and again, as Dr. Harvey, one of our team members, so kindly points out, you should be able to measure that with a standard home-based piece of equipment. So one of the things I think we should be doing maybe a little better in this field is acknowledging the work that came before us that sort of adds some scientific validity to the ideas that we have, and so I'm going to try and do that here just by calling out a few studies. So the first study was by Leon and colleagues, and what they did was they tested this observation of an earlier onset of anaerobic metabolism on the second day of a 2-day CPET, and they tested a cohort of people with ME/CFS and a cohort of sedentary control participants, and what they found is that not only are there clues associated with respiration that I won't go into that we've picked up on for about the past 20 years, but this is corroborated with direct measurement of lactates during a cardiopulmonary exercise test. And so they use sort of needle stick lactates at various different points throughout the cardiopulmonary exercise test, and they found that in people with ME/CFS, they had an earlier onset of lactate accumulation, and at a lower exercise intensity on the second test of a 2-day CPET. But by contrast, sedentary control folks will have a later onset of their lactate threshold. So it's the actual opposite effect, where people who are deconditioned tend to, when they're confronted with a second exercise challenge, they tend to get more efficient with metabolizing lactate, whereas people with ME/CFS tend to get less efficient. So what this tells us is that the post-exertional state matters, and that it is associated with changes in lactate production and clearance that could be important. Following that, published, I think, the same year, actually, was the Gali study, looking at a retrospective cohort of people with ME/CFS classified according to the international consensus criteria, who had been admitted to the hospital for diagnostic workup between about 2011 and 2017. And during this workup, they measured blood lactates at 8 different time points surrounding meals, as well as a fasting measurement. And they defined hyperlactemia, as Dr. Wright pointed out, at greater than or equal to 2 millimolar per liter, which is kind of the consensus of, we think that anything over 2 is an elevated lactate level on a waking fasting measurement. And this is deja vu. You've seen this chart a little bit already. I'll spend a little more time talking about it. The key findings of this study were a very high prevalence of hyperlactemia as they defined it. About 45% of their cohort had hyperlactemia. And this was associated with a significantly greater concentration of lactate at all time points, and significantly more severe disease in an adjusted model, adjusting for age at disease onset, sex, and comorbidities. So not only was hyperlactemia prevalent, but it was also associated with disease severity, and it wasn't sort of just on one measurement. It was across the board that some folks just were higher. So it pointed to the possibility of a cohort that may have clinically relevant high lactate levels. And so Dr. Nikki Cleggbaker and her team a few years later published on home testing, a home testing protocol to measure physiological responses to activities of daily living in ME. And they measured 17 people, including lactates. And they found lactate levels greater than 4 millimolar per liter, which were associated with a higher frequency of symptom reports during their testing. So this kind of points to the idea that you can actually test in the home environment. We still have investigators doing the testing according to a standard procedure and protocol. And again, points to the idea that certain signs and symptoms in people with elevated lactate levels might be more frequent. So again, another piece to the puzzle. So, with these papers, obviously it's all sorted. We can go home now. There's no reason to do more. So no, there was, and so we still had some things that we wanted to find out. The first is what might be the benefit of a completely decentralized platform of people collecting their own lactate measurements and reporting them. Again, at the completely decentralized platform, people who are already doing it anyway, already planning to do it anyway, and sort of creating a survey format in order to be able to kind of form the basis for a database. We also wondered if we could, recruit more functionally disabled folks, more people in the moderate to severe, and very severe categories using home-based testing. And of course, we also wanted to replicate the findings associated with these elevated blood lactate levels that were conducted in rather controlled settings by trained folks. Could we essentially recruit? Could we recruit citizens to do it, lay citizens to do it for themselves and contribute to the science? And so the other thing we wanted to do is to assess the feasibility of this new research approach. Could we harness the power of patient-led citizen science? Could we create a more decentralized platform to increase inclusion? And then also looking into the feasibility of self-report of different dependent variable measurements, which is just a hyper nerdy way to say, can we get good data to be able to say some things? And so our purposes were to determine the relationship between self-reported home-based blood lactate measurements and signs, symptoms, and function associated with post-exertional neuroimmune exhaustion, and that we hypothesized there would be some significant relationships there. So in the way of a design, this was a cross-sectional, non-randomized survey study involving adults over the age of 18 years, reporting at least one symptom or sign of post-exertional neuroimmune exhaustion according to the international consensus criteria, which is a really low bar. And as it turns out, 90% of our participants endorsed them all. We used social media-based snowball sampling to kind of maximize our ability to reach people with the assistance of MECFS and long COVID advocacy groups, online support groups. And after signaling informed consent, participants completed the study survey. There were two versions. One was an intake survey that contained questions that were interesting from a baseline perspective, questions about post-exertional neuroimmune exhaustion, daily functioning, the onset of the condition, the participants' medical history, and demographic questions. And then each participant was invited to create their own login, some super cool logins that will remain secret. But then they could basically indicate that they'd already done the baseline survey. They could put in their special secret code, and then that would allow us to excuse me, link the data to follow-on surveys where we skip all the baseline stuff and we move straight into the reporting on lactate upon waking and 1 hour later, fasting glucose, and a 2 hour later measurement, and then ketones, foods that might alter them, and then whether this was a good day or a bad day, as well as a questionnaire to get at the severity of post-exertional malaise. Participants could access the study survey as many times as they wanted. We didn't have any prohibition. I think everyone was included in the study who contributed at least one measurement, and I think we had one person contribute 13 measurements, and so there was a wide range in the number of measurements that were contributed. And this was a study that was approved by the IRB at University of the Pacific. So we got the data, looked at the data sheet, cleaned up the data, and then dichotomized the measurements. So we looked at this data from a measurement perspective. So while the Gali study looked at it from a patient perspective, we looked at the measurements and the correlates of each measure, because often we have the measurements, and we're interested in the attributes of the patients. Kind of looked at it a little bit opposite from what Gali did. But we used the same threshold for identifying hyperlactemia, 2 millimolar per liter, based on the waking measure. Did some pretty standard statistical magic, looking at descriptive statistics, and then just basically running some pretty standard statistical tests. So the survey was available between May and September of 23. There were 132 unique respondents to the survey. And let's see, I'm just going to move people out of the way here. There we are. From 20 countries, contributing 322 lactate measurements. And again, that ranged from 1 to 12. The median was 1, so significantly skewed to the right, but with an interquartile range of 3 responses. So about half of individuals contributed between about 1 and 4 responses. So you can see here's some of the descriptive data, about 70% women, about a quarter never menstruating, 30% menstruating regularly, about age of about 45 years. We had disease durations between about 1 and 5 years. So I suspect this is sort of our long COVID cohort here predominantly. Anything after that, more the ME cohort. We had some folks, very few folks that reported less than a year of disease duration. Pardon me. Again, about half reported long COVID, and then sort of had a bit of a spread here in terms of other sort of disease precipitants as potential onsets. About 40% of our sample had herpes virus infection. You'll notice that most people endorsed all of the features of post-exertional neuroimmune exhaustion. Again, reporting a median of 5, which means just about everybody reported all of them. In terms of symptoms, again, here are all the symptoms that you see from the international consensus criteria. A median of about 8 different symptoms associated with post-exertional neuroimmune exhaustion. Among people who reported changes in behavior of the symptom, the one that changed the most frequently for them was by the hour or the day, and then a bit more scatter in terms of the one that changes the least frequently. Most people tended to kind of cluster by the week, and then we also had this quarter of people for whom it didn't change, and kind of stands as a bit of a limitation to our interpretation, but I'll get into that here in a moment. Again, a number of different diagnosed health conditions that people endorsed. Over half of people reported a previous diagnosis of ME, a previous diagnosis of POTS, previous diagnosis of long COVID. Those aren't probably aren't totally surprising to people. And then here's sort of the level of function. This is really utilizing the criteria from the UK NICE guidelines. You can see that most people tended to cluster around the moderate to severe range, which is I think maybe a little bit more than previous research. So I think that's a headline of the study. Sometimes it's good just to see what the data looks like, and if you're not used to looking at this, of course, this is an approach that only a mother could or a father could love, I guess. This is called a box plot. And in the purple shape here is about half the data. And the little whiskers here are about 1.5 times the width of this box. And anything that's a circle or a star is an outlier. So you can see that we had, some nice clustering. That clustering was just below 2, just below that hyperlactemia at rest. But we had tons of outliers, including people who are, up here close to 9. And we said that hyperlactemia is 2. Here's postprandial measurements. So this is an hour later. And you'll see that, again, clustering, good to see, but lots of outliers, including up here at I think our highest was maybe 11.7, if I remember from the data sheet. So some pretty substantial outliers. Now, not enough that I think it really influenced the statistical findings that I'm going to share with you, but it's always good to see what the spread of the data is. So the way we looked at this is what's the risk of hyperlactemia given a characteristic that we would refer to in epidemiology as an exposure, or I think in other research terms we might call it the independent variable. And so here you see a significantly increased risk for irregular menstruation, a little bit longer disease duration, 6 to 10 years, 21 years or more. Again, that's not to say that people can't have hyperlactemic measurements without, but just in terms of this particular study. We look at the features of post-exertional neuroimmune exhaustion. Nothing shook out as being statistically significant, but remember, this is maybe a self-fulfilling prophecy because everyone had at least a median of 5 of these. So pretty substantial impairment there. Headaches and becoming frequently ill and taking a long time to recover were significant risk groups for demonstrating measurements associated with hyperlactemia. Interestingly, none of the diagnosed health conditions rose to the surface. So, just saying, hey, maybe there was some other underlying pathophysiology that was responsible for this. It doesn't necessarily seem like that was the case. Interestingly, if a person reported they had a bad day, self-reported bad day, then they were significantly more likely to have a high lactate level the next day. So that's sort of a headline finding there. Now, we also looked at glucose in ketones. We had far fewer hits on our data for this, but just to kind of show you again, some nice clustering there for the glucose measurements, but again, about a third the number of the lactate measurements. So it really limits what we can say. And, really kind of no significant differences based on following a good day or a bad day, the lactate status that we've kind of talked about, as well as stratified based on functional impairment. So more probably to come here, because we only really had a few observations of folks who are hyperlactemic. So one caveat, and one thing that we're still noodling through as a team, is we had a space for reporting foods that might alter, or medications or supplements that might alter lactate or glucose. And so a substantial number of people reported consuming those. And so trying to figure out how we'll adjust the models based on this finding is still sort of an area that we're looking into. So just a caveat that everything that I presented is unadjusted so far. But in the way of a discussion, so that we can maybe have a few times for questions and answers, a few minutes rather, is the decentralized study design is totally doable, and that we found that hyperlactemia is present, but maybe less prevalent than the previous study in the hospital setting suggested, but was associated with relevant functional and symptomatic subgroups of people with ME or PENE, I should say, but not concomitant diagnosed medical conditions, which we thought was important. There were some limitations. Home-based measurements are noisier, and it is what it is. Some different device settings, some subtle non-standardization in how people are doing their needle sticks and when. Also, we had limited control over factors that may affect the accuracy of the measurements, like diet. And then challenges relating to data linkages. Some people forgot their secret code, so we had to kind of figure it out. The completeness of the data, and also integrity in terms of keystroke accuracy and so forth. And we'll be kind of working through some of those issues as we move forward, and continuing to work on the decentralized platform. But with that, I'd like to just stop talking, open things up for questions and cogitations.
Thanks, Todd. We had some questions come up in the panelist chat here. Does anybody want to come up and ask some of your questions? I guess I will start then. If anybody else wants to come after me, that's fine. I'm wondering, can you present again, Todd, and go back to the curves that you showed, the lactate accumulation curves? Or what do we already know about this?
Yeah, I'm going to do that. That's my positive affirmation that I'm actually going to be able to do that.
So while you're doing that, I'll just kind of give the background why I'm interested, why I'm asking you to do this. So after doing the acid test, I was someone who always had low values. I never had anything above 2 at waking, above after having the meal. But then I went and worked with a company called Oval, and I did this sort of testing I was on a stationary bike, and they would do the finger prick, or actually the ear prick, while I was on the bike at different power levels. And I came in the next day. I did the second day test here, and mine was the same as this with ME/CFS. I was worse the second day, and they hadn't really been looking at that, so they thought that was interesting. But the thing I was going to mention here is that in this test, we didn't go above 2. So we were able to capture that curve even at the very low levels, because they didn't want me to get post-exertional malaise. And so if you kind of look at those curves there, you can sort of, even at those very low values, you can see that difference between the ME/CFS patients and controls. So my question was, could this be a poor man's 2-day CPET? Could you use this for people who can't go in and get the full 2-day CPET, for people who are worried about really getting worse afterwards? Could you use something like this?
Yeah, I mean, it's a great question. And I, so allergic to hype, but I do think that there probably is a future for looking at home-based lactate levels. The key is standardization to the extent possible of the exertion. So, you don't want to go back and say that a person may be accumulating more lactate because they're exerting more than another. And so there needs to be some kind of patient referenced way to standardize the level of exertion. But that's sort of the complicated answer. But I think the short answer is yes. I think that could be possible and a great idea.
Awesome. My son is home here on spring break, so he's trying to talk to me. So I'll try to pay attention here. But I saw John come up. Did you have any questions?
Sure. Just a comment of whether it's what somebody's eating or other things. I know I participated back when this was going on and found changes on and off low dose of metformin, which may not be unexpected, but just to see if you've seen that in any of your CPATs or other things.
Yeah, it's absolutely. I mean, all of that can have an effect. The interesting thing is, on CPAT, the changes at anaerobic threshold are low level enough that most medications don't seem to interfere with that. So that includes medications you might take for dysautonomia, metformin, and so forth. Is the submaximal exertion does not seem to be impaired. Where you tend to see the interference is more towards maximal peak exertion. So.
I just more of a comment than a question that I just see very commonly in the space. More clarity, for clarity, is that a lot of patients conflate high lactate with acidemia and being in a high acid state. And I guess I just want to emphasize that lactate in itself isn't an acid, and it doesn't necessarily mean acidemia. And it can actually mean you can also get high lactate in an alkaline state. So obviously Vicky did her lovely N of 1 study where she did do a low acid diet and it helped her. But if you're not acidemic, going on a low acid diet can have some negative effects, and it can cause harm. So I just want patients to be aware that don't conflate acidemia with lactemia. You can do a blood gas test and measure your pH if you want to know if you're acidemic or not. So I think just to make that clear for people.
Thank you, Dr. Carroll. I think that's a great point. We were very intentional about that language, and I think backing up and underlining that point is really important. So thanks for that.
All right, we have some additional questions in the question and answer chat. So the first one says, just wanted to give a heads up that abnormal lactate values and neurological damage can coexist. I just got diagnosed with GBS and CIDP, which had been overlooked because of my general weakness at Bell score of 20. Do you see overlaps with these diseases in your research?
My sense is, that the human body can have multiple diseases at the same time, and so I think we clinicians need to avoid what you might call search satisfaction, where you find a diagnosis and the diagnosis seems plausible, and then you just kind of stop looking. It may be that more than one diagnostic label fits and is helpful from the perspective of guiding additional diagnosis and treatment. So in this space of complex chronic conditions, frequently preceded by an infection, it is not uncommon for people to have sort of a long list of different conditions that all can fit and all can be helpful. And again, I think it's just a caution to us clinicians and researchers that we need to embrace that complexity.
All right, next question. Do you think that there can be some utility in using this as patients to aid in monitoring exertion or pacing?
I think so. And the reason I think so is this association with a bad day. Now, here's the thing that, as a researcher, and you're constantly trying to test your own try not to drink your own Kool-Aid. You know, we tested against the risk of a bad day. So we know that people had a significantly greater risk of having a hyperlactemic measurement after a bad day. But you had a bad day. So what's the role of the measurement, you know, at the end of that? And so I think we do need to do some additional testing to figure out what the specific relevance is to people before we put too much stock in that. You know, it's good to vindicate the underlying physiology. It provides another, I think, kind of grain of sand on the beach, so to speak, as far as things go. But I'm wanting to test that a little bit more in terms of its utility.
Okay, so the next one is any tips on supplements or similar to take before, during, or after exertion to combat hyperlactemia based on lactate results, and your individual experimentation with those supplements?
Yeah, I might not be the best person to address that, but I think Dr. Wright was on it, so I'll yield the floor.
Thanks. Yeah, so and that's exactly why I'd like to write a review, is because I mean, what I tried and what a bunch of other people that I was talking to tried is not exactly a large source of information. And we all know that we react differently and things like that. And a lot of the evidence, there's kind of two populations that we copy. One is the longevity crowd, right, who are trying to live longer. So we're trying to copy them, but they're healthy and just trying to prolong their health span or whatever. And then there's the extreme athletes, and we're neither of those two. But they're the other group that would have experimented, for example, with BCAA, with creatine, with beta alanine, like a whole bunch of those kind of sports supplements and things. So those are things that a whole lot of us tried. But that is exactly why I'd like to write a review, just to see if we can get through some of the noise there and see if there is things that are safe to try. I mean, what's safe to try in ME and long COVID? Arguably nothing, right? But if you're going to try something, you know, everything is start low, go slow. You know, Harriet making the good point there that if there's an obvious problem in the wrong direction, then moving your needle in that direction further, it could definitely cause problems. So I think that could be really useful to get, because of course that's what people want to know. What can I do, and when can I do it now? Because I don't want to wait 25 years for a whole bunch of RCTs to be carried out. But I suppose it's anything to try and make our TCA cycle work better is the general goal. And I think that there's studies out there that show, like, if you do like an organic acids test, I think there might be a question in the chat there about what kind of tests to do. If you do an organic acids test, sometimes you can see that all of the metabolites in the TCA cycle are decreased in patients with ME/CFS. So it just means like I often describe it to my own patients like it's a water wheel, and there's not enough water going into each bucket, so the wheel ain't going around. Yeah, so there's a whole bunch of things. I did actually mean to say in my introduction that, you know, this wasn't a whole bunch of recommendations on interventions, because none of them are proven. Specifically the DCA that I mentioned, I mean, I feel like that was a bit of a wild experiment on our behalf at the time. We were a little bit, you know, we're just desperate and trying things. But I think there's papers out there that show that even one dose of DCA can massively increase your lactate as well. So don't try that one. Don't try that one at home, kids. Some of the amino acids I'm a big fan of, actually. So maybe that's a safer place to start.
Right.
Thank you, Dr.
There's another group that could be useful for us, is groups with other metabolic diseases. Now, I'd say it with caution, because they've got a known disease and we can often pinpoint the part of the cycle that's crashed. And if you look at the evidence that they use, it's incredibly weak, and a lot of it is based on clinician experience. The guidelines are, this is what we use in our clinics, and they also tend to recommend, or at least think about, the same things that we look at, like CoQ10, B vitamins, vitamin C, vitamin E, ALA. So they're kind of already doing in standard and recognized metabolic diseases what we're already trying. So that kind of speaks volumes, that even in recognized diseases, we're not that much better off, unfortunately.
Just want to make a comment of the coexistence and the impact of being inflamed and not inflamed on what happens with metabolism. So if broadly you have the Krebs cycle and efficient oxygen creation, that tends to happen in a non-inflamed state. And if you're in an inflamed state, you go to a less efficient place with glycolysis and fermentation and not doing all the, basically not producing as much ATP. And that tends to happen in the inflamed state. And so it's also possible to treat inflammation to end up in a better metabolic spot.
Thank you, Dr. Hutton. Okay, so we'll move on to the next question, which is which blood or genetic tests help understand which part of the mitochondrial metabolism or precursors like pyruvate cycle are not working? Hold on a second, I can't read this. I can't read the second part of that question for some reason. I don't know if you know, Kat, if you can if you can
just
read
the bit
it.
that says, can one identify this somehow with lab tests? It's the second half of that message, is it? I don't know. It's,
Thank you. Thank
no
you.
problems. So again, I mean, if anybody else has any suggestions, jump in. I had just mentioned the organic acid test just because it's accessible. So it's a urine test, which you can do at home. I mean, accessible in the sense that it's $500 or whatever. So it's not totally accessible from that point of view. But it can be done at home. It is used clinically. You know, interesting that Harry was bringing up those kind of genetic metabolism issues to diagnose some inborn errors of metabolism. So, you know, that could show up, its potential, but what we'll probably be looking for in most people is more subtle kind of clues. And it will measure a whole bunch of the different metabolites. And it's, you know, it's quite a puzzle getting the data back from it. And you're just trying, because there's so many redundant pathways and there's so many ways to feed into the same cycle that you're trying to make sense of, well, if this one's not high and that one's low, you know, what's missing? Is there a block here? Or is there something else feeding into this pathway? Is there something else draining out that pathway? So it's certainly not a black and white answer when you get the results, but it can point you in the right direction of things to look at. The other one is probably best in serum is just a pure amino acids test. I can see Kat like nodding her head there. I know how useful we found it. And just looking at, again, which amino acids are either being depleted or maybe just not being absorbed in the first place, or, you know, again, what's turning into what in terms of the interchange of those amino acids. I think that, and that can be, depending on your access, that one is probably much more cheap and cheerful, except that it's a blood draw. So from a physical point of view, you might have to attend somewhere. There used to be an at-home test kit actually in the UK, and that was only about £45. I don't know if they're still doing it. I think they might be. Sarah Screen was the name of it.
Thank you, Dr. Wright. So the next question goes in that direction as well, into what helps, how to support the Krebs cycle if there is some functionality left.
Yeah, there is loads of different ways. And I think, you know, you could probably mention every single vitamin, a whole bunch of the minerals, and then all of the other nutraceuticals like carnitine and whatever else. And I do feel like, sadly, it's still a trial and error scenario, and that everybody seems to react slightly differently. So, I mean, I would have tried high dose ALA, thiamine, carnitine, all sorts of things didn't do anything for me. Whereas somebody else would say, because I can't get out of bed without ALA, you know, so it really, really depends. And I feel like we're sadly still at that level of there's a list of 50 different supplements that you can try, and you might need to try them at different doses. So some people will take kind of an entry-level dose, does nothing, but they find that they get a much bigger benefit if they take a much higher dose. And sometimes it's a brand issue, and how you're supposed to know that, I don't know, but certain brands of supplements seem to be more effective than other brands. So that's why Twitter has been so useful, because at least you can learn from other people's experience and other people what they're buying and spending their money on and everything.
Yeah,
The
thank you.
comment
And
about, I was just going to say the comment about the brand is really, really, really important. So if you think that there's a particular problem you're trying to address or area of your biochemistry, and the supplement or nutraceutical or drug should be doing that, and it doesn't, if there's an alternative that has different theoretically inert parts in it, or just filler parts in it, trying a different brand can make a big difference. And if people want to really dive into that, there's some on the Renegade Research channel, there's a Dr. Afrin's MCAS discussion goes into that much more, but where one drug or nutraceutical makes somebody totally worse, and the exact same drug in a different formulation with different fillers is wonderful.
that's a really important point. I'll add to that and to the rest of the conversation. I developed a combination formula that we're going to be doing a formal trial on, specifically for PEM, right? Where I have observed in myself that there are changes in the lactate measurements as well, before and after. So we're going to be including that in that trial. But what I wanted to say is that in testing different supplements, berberine is one of the components of that mix. And it was very different with the different types of berberine, the different brands and the different formulations as to the results that we've seen preliminarily. So that's a really important point. Okay, so the next question is,
Wait a
how
minute,
long
drop in.
after?
Hold on a second. Add to that as well. I just wanted to let people know, if they don't have a practitioner and they can work by Zoom, the person I work with is Mike Creeder from MikeCreeder.com. He is a genetic coach and a nutrition coach, and very good at reading these organic acid tests. So if it's like over your head or over your doctor's head, and you want help going through it, and a little bit of warning about your genetics, like, oh my God, your results say take this thing, but your genetics say you can't take that thing. He's helped me sidestep some landmines. I still stepped on some, and we had to backtrack and figure them out. But it was nice to have a partner that could do that, and he can take clients from around the world.
Thank you,
I add
Ellie.
to that as well, in that because we don't quite know ME specifically what it is, and it might be different between people, I think, and I know this isn't always feasible with the current medical system, but if you can work out any aspects of pathology and target them first, that can be really helpful. And some of it can be quite simple, like you can do a POTS test at home, and if you have POTS and you can show that to your doctor, you're more likely to get treatment. You can play around with MCAS medications to see if there's an element of MCAS that can be contributing to your fatigue, to your post-exertional malaise, to general symptomology. So if you can find out other aspects of your disease and target those first, it can be a little bit quicker than just guessing and trying things at random.
Thank you. All right, so next question. How long after physical activity we have to measure our lactate to be accurate?
Wow, what a good question. And maybe something we need to look a little bit more into. We know that there's an abnormal accumulation of lactate. We're assuming that there's a normal clearance, but that's an assumption. After physical exertion, probably following the time course of your post-exertional malaise is where to go with this. So again, remember that one of the key findings of the study was an increased risk of a high lactate measurement after a bad day. So that means that you're having a relatively good day, which makes an assumption that you have good days, which is a big assumption in some people whose symptoms don't change. So I would say at least as long as you're having bad days, potentially would be relevant to measure your lactates daily.
So that goes to the next question, which is measuring, knowing that one feels bad, but what can I do with this high lactate is what the person is asking.
Yeah, I think it kind of goes back to continuing your crash care plan. Lots of great ideas coming forward from the panel down in the biochemical weeds that are not my specialty. So I'm so grateful for a team who can manage those questions, but also, to the extent feasible, pacing is another option. And it's a lifestyle. It's not a treatment. It's not a cure. It's a Band-Aid, but it seems to have an effect in some people. So again, think about your entire suite of different treatments that you do in order to rectify a crash, to kind of pull yourself out of a crash if you have those interventions at hand that work for you, and those would be what you would continue to do. So the Bateman Horn Center has a really good set of resources out there in terms of a crash care plan. And so that I've always recommended those to people in terms of just organizing, for the bad days, and some really key tips and good ideas and some planning tools to be able to assist you with that.
Yeah, because I think, oh, sorry.
Go ahead.
I was just going to say, I think sometimes you think you might be in a crash, other times you think, well, maybe I've just got a virus. I mean, who knows? There's so many different symptoms going on constantly, and then sometimes we think we're just in a decline, or is it rolling PEM, or it's kind of hard sometimes to figure out what is actually going on. So if you've had some serial measurements that show, for me, my lactate can be somewhere between 2 and 4 when I think I'm in a crash, then you can almost use it as a personal biomarker. So, I mean, I think that was Naomi's reading the other day. She had been in a car. She certainly thought she was in PEM. She certainly thought she had a crash. She took that measurement, and like I said, it's going back to the validation, and that really says, right, this is a serious situation. I am not moving from my bed. I'm doing all of the things that I have to do, rather than, oh, well, maybe it's just a cold, or maybe there's just something else going on, or whatever. So I think it can be useful for that.
And the other thing is, if your provider is open to having these discussions, maybe discussing timing of the medications that you already have or maybe prescribed. One of the things that I observed in myself is that one of the medications that I take predictably lowered it, and the symptoms improved, after. And the same with the PEM formula that I mentioned, but not to the same degree. And we will be studying those, but in the meantime, you can have these discussions with your providers and see if any of the things you already take or that your provider is interested in prescribing for you. If you can test when that is high, does this medication that I already take, does it have an effect on the measurements, but more importantly, on the symptoms, and see if you can make your own personal correlations that way.
I was going to put in a plug for our next talk, which addresses something that may apply to people, bad veins, whether it be from collagen issues, genetics, injury, and that when you have bad veins and you overdo, or you sit too long, or you do something upright too long, that you put them into extra distress, and they emit certain peptides, which can then give you headaches, migraines, all kinds of things that don't seem like they're coming from veins in your groin. And for many of the people that have been studied and treated for those bad veins that can be treated, they've done well. So I hope people can tune in on April 11th to hear about that, because it's another avenue to see if we can't get the metabolism to work better, because we get blood flow to work better.
Thank you, Ellie. Our next question is for Veronica, if you want to come on.
Hi there, thanks very much. Hi, Todd. I was just wondering, did you compare the lactate levels between the ME and the long COVID patients?
Good question. And the answer is not yet. That's sort of on the part of the subgroup analysis as we were kind of going along that we're planning on running before we take this forward to publication. But I thought it was really interesting that the odds ratio for hyperlactemia versus no hyperlactemia really was not significant for either an ME diagnosis or a long COVID diagnosis. And that might just be a self-fulfilling prophecy because that was who we were studying. So, you know, if we had included, you know, a greater maybe spectrum of fatigue-related illnesses that don't involve PEM, then we might have seen something relevant there. But yeah, it might be worthwhile to look into that, and that's definitely a plan that we have. So I appreciate the question.
Okay, yeah, no, because I was thinking on the line of, you know, this differential level of microclots found between, you know, there is a difference accordingly to Pretorius about lower microclots still present in ME. Well, I know it's very hard to sometimes differentiate when you have a patient that has both. But I was wondering on those lines. And also, which kind of protocol was I'm just thinking, how could we apply this to groups of patients? Like, which was the protocol for measuring the lactate? Because, you know, like, I know there I appreciate very much the approach that we have to do this in real life, because sometimes we want to control so much in a lab or in a study that sometimes we're probably missing the real life. But when we go into real life, probably we feel we're missing the controls. So I'm just thinking on the line on how to design a protocol that could help people to do these measurements in a way that we find a better standardization within the normal day-to-day life.
Yeah, I just want to piggyback on that to say this was an exercise in self-development as a scientist for me, because I'm so used to come to the lab and we do this thing and we do it the same for everyone, and here we're having people do things at home. And now there is a resource that was circulated, I am aware, among folks to try and standardize that process a little bit, and maybe someone on the panel who can sort of speak to that. So it wasn't completely the Wild West in terms of the testing, but it was definitely a lot more decentralized than any project I've ever done before. And the cool thing is that we were able to detect a signal in and among any noise, and we did have. I think part of the reason we were able to do that was we knocked down some of that background noise from, you know, some standardization of the protocol, and I see that Tess has placed a link to that in the chat.
Yeah, I think we wanted to kind of mimic the T1 and T2 on the galley, so like a waking and a postprandial, which is interesting because in theirs it went up and in ours it did not. So again, maybe there's a diet control there, or maybe people weren't eating at all, in fact, between, I don't know. But we just said, well, if we're going to be collecting data from home, yeah, we should have some kind of standardized. And we've picked two because partially because the lactate strips were expensive, right? So we couldn't be doing like 8 time points because all the lactate strips would be gone. So there was kind of unusual constraints, let's say. But we had so many conversations about this idea about it being the day, recording the day after you feel unwell, rather than being right in the moment when you feel unwell, when you feel the crash, when you're in the middle of a crash, whatever it was. So absolutely, you know, if you think it will be more useful in real life when people understand, well, okay, I'm a high lactate person, like Naomi on her 4.4 lactate the other day. She didn't take that, you know, when she woke up or 1 hour postprandial. She took it, you know, whenever she felt the worst to figure out how she was doing. So yeah, I think we probably did miss some data, but then, you know, as you say, you can't have it just being, you should just measure whenever you like, because we had to collect the data somehow. So there's definitely a difference.
Thank you.
Just some of the variants also, I think, Todd, you said that because it was at home, the number of severe people in this cohort was different than in some of the other measured cohorts. And a severe cohort, one could think, might have higher lactate is important. And to me, that brings up another piece is of how do we label what somebody has or what situation they're in? Is it long COVID? Is it ME/CFS? Is it a genetic predisposition? Is it something else? And it may be all of those, and that may be the underlying piece. And it might be that, long COVID at the beginning is one thing, but then if it's going on for a long time, you meet the criteria very often survey-wise for ME/CFS. So is it a level of body's response to something over months and years that ends up kind of getting you in that spot? And are there a lot of ways to get into that position? A lot of starting points. Is it pollution? Is it plastic? Is it inflammation? Is it infection? Is it all those things? And I don't think any of us know the answer, but it may be very helpful to double check what we think we know is true too.
Good point, Dr. Houghton. I mean, just to kind of bring back some of the data from the study, just in the way of describing our participants. We had about a quarter of our participants report that their symptom that changes the least frequency doesn't change at all. So that suggests to me we may have had a substantial size of cohort of people in slow rolling PEM. In addition, as you pointed out, we had a pretty substantial number of people. I'm just kind of doing the quick math here. Over half of our participants were moderate to severe. Between about 30 to 50% of expected functional level. So I would anticipate that our severity was much worse than in other studies. So some good points you raised there.
Thank you. All right, our next question is, would increased lactate be contributing to the high rate of reported GERD heartburn in long COVID?
I'm going to say I don't think so. If anybody would like to be in agreement there. I think, are we talking about again it being kind of acidic, or in terms of just because your metabolism's slowing down, this idea that all of your motility is slowing down, that kind of thing. So I don't know is the answer.
I agree. I don't know. I could postulate or just think through that somebody could be inflamed and have higher lactate, and somebody could be inflamed and have more GI distress. And it could be that underlying inflammation ties the two together. And there are just so many places in medicine where it's that third thing that you don't see that makes the two feel like they're right connected and causative, which they might not be.
I just feel like you described my entire research career in this area, Dr. Houghton. It's that third thing. What is that third thing? I don't know.
Yep, absolutely. All right, next question. Have you seen, either in the study or without, significant lactate increases for higher carbohydrate intake on the previous day? A homemade pasta meal on the previous evening sent mine beyond 4 millimoles on the breakfast measurement.
I haven't, but only because I haven't heard about it, and now I'm intrigued by it. So now I want to take a more careful look at it. Now, in some of the subgroup analysis, we do need to look at the correlation between waking glucose and lactates. I think that's an important thing to take a look at. We also have what we are assuming are postprandial measurements. We can take a look at those correlations as well. And so that's a subgroup analysis that we haven't cracked open yet, but we'll be doing so before we take this forward to share with the broader world. But yeah, I'm not sure, but I'm really intrigued by the question.
All I could think of there. Oh, sorry, go on.
No, go ahead.
All I could think of there in terms of, from kind of mouth to metabolism almost, that something like a very simple carbohydrate meal, in somebody who maybe has digestive issues, that's easier to absorb. Glucose gets into your system quicker. It's absorbed right at the top of the small intestine. So that's like almost quicker getting to the point of pyruvate, like your glucose to pyruvate via your digestive system, than maybe something like a protein meal that has to be slowly digested, that potentially people aren't digesting very well at all. So like it's almost like there's just more fuel going into that metabolism and then getting shunted to more lactate than if you were to eat a protein or a fat meal.
Thank you. Okay, so the next,
Can I-
Ellie, go ahead.
Yeah, I'd like to add that, when you guys did this study, the over-the-counter glucose monitors, continuous ones, weren't available yet. So now people have that from Stelo.com, STELO, to add to any other home studies that they do. I don't know if it's available over in Ireland yet, is it?
It is, and in the UK from Abbott, there's a Sense Libra. I think they're on their second.
It just seemed like a
third
miracle when
iteration.
it finally became
Fabulous.
available in the United States.
Yeah,
Yeah,
they
it's
had
like
it before we did. Yeah, about I think a year or more before we did.
Yeah, and it's like €60 for 2 weeks of data. It's great. It's really good value.
Yeah. Okay, so the next one is I did the acid test, but would have no way of knowing which medications might affect acid levels. So I don't know how well that part of the survey. If I recall the survey structure correctly, maybe this happened with others too and might impact the results, ?
Maybe, and that's part of the noise. And it's part of the noise that we kind of live with. I think the survey involved a few examples of different types of foods and different types of nutraceuticals and so forth, but nothing exhaustive. And so we are giving back a little bit of that, control. And but interestingly enough, we had 3/4 of people, or 3/4 of the measurements come with an endorsement that people may have consumed something that altered the measurement. So there may be a few more folks that maybe underreported that, but if anything, I think maybe there was some overreporting happening. So I'm not sure what direction that might influence the results, but again, it argues for adjusting those odds ratios according to the report of consuming substances, foods, nutraceuticals that potentially could modify glucose and modify lactate. So I mean, definitely the comment is well taken. And we'll look into it.
I just was going back into the Twitter history and was looking at some personal values as fasting and then postprandial. Within a couple days, fasting was 0.7 and postprandial was, or after an hour after breakfast, was 1.8. And then 3 days before that, fasting was 1.9, and 3 hours after breakfast, sitting at a desk, was 3.4. And so and I can tell you, I didn't feel odd or off in any of those, but definitely had some neurofog at the time. But the numbers can change for sure.
All right, so our next question is, does having poor circulation with dysautonomia or POTS also contribute to the increase in lactate value, in addition to having an inability to clear in ME/CFS?
Yeah, so I think that goes back to even what John was saying in terms of like we were talking about some of the nutraceuticals that can kind of help your pyruvate get on into the TCA cycle rather than going to lactate. But why is that all happening in the first place? And one of the predominant, like talking about the root causes, potentially is the lack of oxygen being delivered to the cells. It's really fundamental. So depending on why that is, right, whatever the root cause is, but obviously blood flow and dysautonomia would be one of those for sure, and microclotting and a whole bunch of other things. But the reduced oxygen is going to trigger your cells to be going into the anaerobic glycolysis instead. Big factor.
At a biochemical level, there really is sort of you can think of a switch that occurs. There's something called HIF1 that tends to be inflammatory, and there's something called NRF2 that tends to be not inflammatory. And if you have oxygen missing, because whether it's from lack of blood flow or whatever, then HIF1 drives into the cell where it makes stuff, and it makes inflammatory cytokines. And when you get the blood flow, when you bring oxygen back, that HIF gets cleared out and NRF2 goes in, and that makes the things that build and grow.
Thank you, John. Okay, so we have Dr. Louise Olive that has a couple of longer questions. So we're just going to bring you up to ask those questions in case it necessitates some back and forth. If you want to remain off camera, you can just leave your
Actually,
camera off
I
as
don't
well.
see
Yeah.
her in the attendees anymore.
Oh, okay. So let's try to ask this and it'll be in the recording. Thank you for all your work on this. I work half-time as an NHS GP and half-time functional breathing practitioner. The issue I am seeing is the switch to lactic acid is dependent on the underlying breathing efficiency of the individual. I see those with complex conditions are carbon dioxide intolerant. So switch to anaerobic metabolism earlier, but this can be changed. If you are more tolerant to carbon dioxide, you maintain aerobic metabolism longer. Are you considering this?
So what an interesting comment and question. So you know, as a physio, I use breathing techniques a lot in my practice, and for lots of different reasons. And I have close colleagues who are respiratory physios who are probably way sharper on this than I am, and I wish they could be here to hear their perspectives. But you know, as an exercise physiologist, I think about is the dog's tail dog wagging the tail, or is the tail wagging the dog? And what I mean by that is the metabolism causing the underlying breathing pattern dysfunction, or is the breathing pattern dysfunction causing the underlying metabolism? And so my hunch has been that the breathing pattern dysfunction is occurring because of the metabolic dysfunction and not the other way around. Now I know that that kind of questions the premise of the initial questioners you know, sort of thought there, and I don't mean to do that, but as I think about this, I'm thinking about people having sort of a dysfunctional aerobic metabolism, keeping them in anaerobic metabolism, potentially elevating the breathing rate in order to breathe off hydrogen ions that are associated with the elevated lactate level, which is sort of how we normally sort of think about this. You know, when I use breathing therapeutically in my own practice, I'm thinking about it as a way to sort of tune down the sympathetic autonomic nervous system. There are some other benefits that I'm looking at. I'm not necessarily looking at it to try and reboot or reset the metabolism. And I hope that's not an unfair characterization of the commenter's premise. So just so you know, that's sort of my bias as I look at this. I'm open certainly to thinking about it the other way around, but have not necessarily played with that to the extent that I think the person asking the question has played with it. So I want to be fair there.
Thank you.
I think
next
it was
question.
interesting, sorry, and just in terms,
Oh,
because
go
Vicky Vandertost would you know, ascribe to that a little bit as well in terms of breathing and the whole diet manipulation of the acid base balance. But to me, it did seem like that was a little bit after the fact, like you say, kind of like after the metabolism issue has occurred. But what was interesting was once she corrected it, she then just got better and better. So it struck me that whatever was driving the initial change must have been gone. Like her trigger wasn't ongoing, so that she changed that acid base and then she got better and happy days. But if that initial driver, this underlying cause, whether it's an oxygen depletion or whatever it might be, is still there, then that I don't see how the breathing part would get you out of the initial trigger.
Thank you. Next question. Do you think the ischemic limb test is effective for identifying abnormal levels of lactic acid that might be treated? My son with ME/CFS has had the test with critical values during the test, but it returned to normal by the end of the test. He was told his test was normal.
Haven't played with that one.
I think Kat tests her.
Yes, I was hoping that Todd knew more. It's more in your wheelhouse. So now I'm going to state right out, like I may have my own personal biases here. So I am a carrier for McArdle's, which is a glycogen storage disorder for which the ischemic forearm test was originally developed. So there are 2 points I would like to make here. One, having been told the test was normal, right? How often do we hear this? So that test, being originally developed for McArdle's, was developed to detect a lack of lactate rather than excess. So depending on, the practitioner or the lab involved, it may be that they just don't have a higher limit and that they won't ever flag a higher limit. So I would, read the results with that in mind. The other thing is, I personally think that test should be done away with entirely. I think it is simply not worth the risk, because the only people who are going to come back with a positive result, where it is clinically relevant for that test, are the people who are most at risk of extreme damage from that exact same test. For example, so it was developed for McArdle's, and practitioners no longer, specialists in that area no longer use it or recommend it because of the extreme risk of rhabdomyolysis and even compartment syndrome. Like, there have been, rare, but there have been cases of people losing limbs due to the test. So I have some personal issues with the test there. So I would just say it's generally a fairly dangerous test, generally not worth the risk from my point of view. But also read the results that you do have with keeping in mind that it is generally looking for a low result and not a high result. So we may see something different here.
Something else to maybe think about, not just with that test, but in general, is what's happening in the blood. So people end up getting their pulse ox done, and their pulse ox can stay totally normal, and yet they're in the periphery, you're not getting enough flow and oxygen and nutrition. And so how can that happen? And the body can shunt or take things from the artery oxygen side to the venous side, and without going through that microcirculation all the way down at the end. And so that's an important piece on a lot of these tests, to double check. And a number of people, it's hard to get the test, but a number of people have had venous blood gases show really low oxygen saturation in the veins coming back, and so there's whatever's getting there is getting extracted, and it's but thinking in your mind's eye that there could be a difference of what's happening in the bigger vessels and what's happening in the small capillaries and the microvessels that are actually feeding the tissue.
And I appreciate those perspectives, and just to kind of build on them, as I think through the bioenergetics of the setup, you're trying to make a determination of sort of what's going on based on depleting the local storage of glycogen, this is a metabolic system that works in people with ME/CFS and ME-like conditions, and so I wouldn't really expect for this particular test to reveal much in the way of anything interesting, because it really, at the end of the day, what we think is that there is a problem sort of downstream with that has more to do with the use of oxygen as a substrate to burn fats and sugars, and so it's kind of just testing the wrong energy system.
All right, our next question, I'm assuming, is in the context of high lactate, but it might just be in general, and it is how to reduce inflammation.
I feel like we could do an entire session on just
I
that.
know, that's quite a big question, isn't it?
It's a big question.
Yes.
Yeah.
Who wants to get started?
John, I feel like this is going to go for you.
Yeah.
So if you think of this is the way I kind of conceive it. So if you think of at the smallest vessel, you've got something on the ends going in, the oxygen on the artery side, and on the other side you have the vein that's deoxygenated, and in between you've got the little capillaries that have the endothelium, and they can get spike in the glycocalyx calyx, or if it's your gut, you can get films and have columnar cells get leaks and all this stuff that you can end up with swelling in the tissue in between. But if you think of there's a blood vessel piece, and then my picture's backwards there, so it's very hard to there. Anyway, and so then here, we'll try to do it this way. There we go, I think. Yeah. Wow, this is a good cognitive test of trying to do things in the mirror. Anyway, and then you've got lymph on the other side that's nearby, and that's taking out the garbage. So when the cells break down, when there's autophagy, when the parts of the cells get broken up, they get recycled, and that's very important. And then you have this tissue in between, this space in here, and the mast cells are sitting there, and they can get degranulated, and when they do, they inflame and so on, and that can start a whole bunch of stuff. So in terms of the inflammation, if you think of trying to stop the inflammation on the way in and stop the inflammation in those tissues in between, you might be tackling it in a way that works. And so stopping it on the way in is general swelling. If it's the spike, you can do things that affect what's called the toll-like receptor, 4 receptor, which is TLR4. People talk low-dose naltrexone works in that spot, curcumin works in that spot, and so do some others. And then the things that attack MCAS, the antihistamines, help to keep that inflammation from happening in that tissue between the blood vessels and the lymph. And so that combination is a good one, but none of that works if the blood's not flowing. So then trying to do things to break apart the microclots and get the blood flowing so the natokinases, the lumbroKinases, and so on can uncork the far end of it. And that collectively may be a systems approach to trying to get the inflammation to go down. And one thing I'll say and then stop is people think sometimes of, steroids, good or bad. And many of these things are not A or B. It can be horrible and it can be awesome. And so a quick burst of high steroids can wildly quiet inflammation that might get blood flowing and other things happening and healing going on. But a low dose of steroids over a long time can cause a whole bunch of problems. And so how it gets applied is very important also. And you try to slam down acute inflammation if you can to get things moving again. So I'll stop there. It's one of my favorite subjects.
I might just add, just from kind of like a nutraceutical point of view, that like, again, if you have an ongoing trigger, your immune system isn't going to start ignoring that, right? So, I mean, whether it's an infection or a pathogen or whatever else that is there. So you might have to deal with that. But let's say that's a needle in a haystack scenario and you still can't find out what it is and you don't know what's happening. Then generally speaking, trying to keep, it's a little bit like the whole diet breathing thing for acid base. It's like trying to keep your body in more of an anti-inflammatory state rather than perpetually throwing fuel on the fire, let's say. So just doing things like having a more anti-inflammatory diet, eating more omega-3 rich foods, not eating a lot of processed foods, looking at your gut, because a huge amount of immune activation comes from your gut. So your beneficial bacteria, addressing leaky gut, that kind of thing is and I think we all probably know that's not the solution, right? I had some shocking gut biosis going on. I had leaky gut, fix it all. Did I feel any better? No, right? But might it have perpetuated the cycle a bit longer? Because once I did find my trigger, then I did become better. So I think it's part of trying to get your body almost ready so that when you can find that trigger and solve the problem, then your body will be in a better place to stop the cycle.
Excellent, thank you. Okay, next question is, what about doing genetic tests like HATS, HLA-DR, HLA-DQ, and MTHFR, etc.?
I mean, I'll comment on the MTHFR piece. I feel like if, it's one of those things that's probably involved in so many different processes in the body. It's definitely not the root cause. Is it part of a process? Yes, possibly. If your folate cycle isn't working properly, then new cell synthesis isn't working as well. Homocysteine is being increased. There's more inflammation. So I think it's something that's reasonably simple. So what we do in our clinic now, instead of paying for individual genetic tests, because there's a whole bunch of tests out there that were like, oh, we'll look at your hormone DNA, or we'll look at your, I don't know, whatever else, liver DNA, your detoxification DNA. Just get any genetic test on the market, right? The cheapest one at the moment, I think, is by MyHeritage, and it's 35 euros. Or Ancestry or whatever is 60 euros, and they're always having sales. And then you download your own raw data from that. And then you have that raw data forever. Now, it doesn't cover all the SNPs, so it is not genome wide. You're not getting everything. So each test company will cover different types, right? But at the same time, for 35 quid, you are getting some data. The other thing I want to say, though, is that they do not guarantee accuracy. So there has definitely been, so I wouldn't be using it to diagnose genetic conditions, but if it's something like you just want to check your MTHFR, do not be spending 250 euros on some private test for that. Download your own DNA data. And Genetic Life Hacks is a fantastic website. And Debbie Cotton is amazingly helpful.
Her, and we're going to have a custom panel soon. Yes, she's been phenomenal.
And so generous. Yeah, she's great.
Yes. Oh, yes. And with at least in the US, Mother's Day and Father's Day coming up, pretty much a guarantee that all of these sites will run. That's how I got mine done originally. You know, when those roll around, they tend to be, you know, sometimes even close to 50% off. So that's definitely the time to do it. Often if you can work with some of the common program readers, once you do download your raw data, they'll actually know, like, you know, Ancestry typically makes a miscall at like these 3 locations. You know, it tells everybody they have this when they don't. So sometimes you can even further narrow that down as far as the typical mistakes of them. But yes, absolutely worthwhile. Obviously, some privacy concerns, as we've seen with 23andMe, but there are some ways around that. And I'm happy to talk to anybody about that. I would also like to add, you brought up, Ciara brought up inborn errors of metabolism earlier, and I mentioned McArdle's, which is one of those, and having a sort of the broad spectrum DNA test is a really great way to take a pitchfork to that haystack to try to find your needle. Again, they tend not to be the original, you know, the primary driver of disease, but they are one of those things that can keep the disease state going. So once you can identify those and treat or remove that cause, it makes everything much, much easier.
Thank you, Kat. Anybody has anything else to add to that portion? No? Okay, so we'll move on to the next question, which is, were there any correlations with reading time of day or post-meal? Or is this something for future analysis?
I want to try and understand the question.
I'm assuming it's on lactate levels. Yeah, if there was any correlations with
super interesting.
the post-meal or the earlier time.
Yeah, so certainly, so the waking lactate measurements seem to be sort of a little bit more stable. The lactate measurements, you know, the postprandial lactates tended to go up, and you know, in people who had higher lactates, they tended to go up a little, maybe even a little bit less. So it was interesting, if you sort of woke up high, you didn't go up quite as much. I have to go back and look at the change scores because I didn't look at them as carefully before this. But that it sort of makes sense that if you're already high, you're not going to go up quite as much. You sort of just see that across a lot of different variable measurements. In terms of, you know, if you start high, you've just got less room physiologically to go up more. And as for the relevance of the change, that's another subgroup analysis that we really should probably look into, is the change between waking and postprandial measurement or 1 hour measurement. You know, was that more associated with good days and bad days and severity and so forth? That's something that we can go back and take a look at. In the preliminary analysis that I presented, didn't look like the change scores were very relevant. So.
Thank you. Anything else, Ciara? Okay. So the next question is, has any of the testing checked lactate levels after exertion, then noted if it caused PEM the next day, to see if this could work as a prediction versus correlation to how you feel when you do the measurements?
Not in this study, but there have been studies that have done that. And I think one of the things that would be really helpful is to combine waking lactate measurements with the change in lactate dynamics on an exercise test. Obviously, that methodology is fraught. It's not without risk. I think that's pretty well characterized. So it wouldn't be for everyone, but it's just because it's not for everyone doesn't mean it's not for someone. I might have to talk with my colleagues at the Workwell Foundation to see how we might be able to pull something like that together, because we could do a correlational analysis between waking lactate and then the dynamics of that lactate accumulation curve. So that could be a really interesting question. We just haven't looked into it.
Thank you. How are you doing for time? I know that we have scheduled for another 7 minutes. We have another couple of questions. Is that okay?
Let's go.
Okay, wonderful. So this is more of a comment. I think on days with doctor's appointments, I am mostly housebound, and when I would expect PEM the next day, I use enoxaparin injection, and my symptoms the next day are not as worse as I would expect them. My lactate levels showing this too. They are lower than without.
I mean, I'm all for it, so I mean, I was housebound, moderate, low, like UNCAP 3-ish, before I started taking enoxaparin. So I would imagine that my kind of long COVID pathology was very driven by microclotting or somewhere along those lines. So that sounds similar. So I do wonder, has that person ever tried a more prolonged approach to the enoxaparin? Because I was put on it for a month as a trial, but I knew after a week that things were going great. So I think my doctor was just like, great, let's just stay on it for a while. I ended up on it for 9 months, which was too long, but I probably reached my maximal gains by about 3 months in, but it definitely took 3 months to get from housebound to what I would have classified as mild then. I mean, I was still getting PEM and all that kind of thing, but it was a massive improvement, but it was definitely slow and steady over the 3 months. It wasn't just like a one-day situation. So I wonder, has that person ever tried staying on it, considering it makes sense. It makes sense pathologically, and it makes sense for them.
And from a pathways perspective, what's called the RAGE pathway is low molecular weight heparin is one of the most accessible ways to quiet it down. And if you dive into the biochemical details of it, there's a word calprotectin, which is one of the constituents that's causes trouble. And it turns out, just to make everything confusing, it's an identical synonym with something called S100A8 and A9, which will show up in other pathways. And it turns out they're referring to exactly the same thing. But the combination of trying to go after your toll-like receptors and the RAGE pathway makes piles of sense here from an inflammatory perspective. And if you're outside of the US where solidexide is available, that's an oral version of a heparin that a prodrug that can break down and potentially would have a biochemical effect here as well.
I was put on heparin sodium back in 1999 when Dave Berg made his rounds in the United States, trying to convince all of us with ME/CFS that we had hypercoagulability. I was on it about 4 years, probably 6 months too long, but it took me 3.5 years back then to reach my max level. As soon as I saw my cytokine levels from Dr. Patterson in 2021, I said, oh, I could have been on heparin and helped myself after COVID. So I've been on it since fall 2021, and I'm just now starting to feel like I could probably back the dose off. I don't think I could stop it, but I could back the dose off. And I can tell because the injection sites get a little bit bruisey, whereas the first 3 years they didn't. Has it done as much for me as it has for you? No, but what it did for me is still a miracle for me. So I hope people find doctors that are willing to work with them on that.
Ellie, your statement about the shot spot from low molecular weight heparin being bruisey or not bruisey may be a really good sort of longitudinal indicator of what's happening. It's a very clever idea.
Okay, I'll take pictures and store them up.
Wonderful. Okay, the next question is, wouldn't more severe patients be less likely to have higher lactate levels since they are less likely to be able to overexert due to limited movement? They would also probably have adjusted their diet and pacing after years of experience, whereas a person with less restrictions may be able to get into deeper energy debt.
Yeah, wow, what an interesting observation. I sort of think about I'll gently push back on a characterization that Dr. Wright mentioned a little earlier about how patients are not athletes, not elite athletes, and I would say that actually you're elite anaerobic athletes just to go to the bathroom, and so ultimately it's an issue of when we talk about severity, I think, especially in the existence of slow rolling PEM, it's very possible that just moving in bed is now considered an anaerobic activity that can spike lactate levels. So it's all a matter of scale as far as activity is concerned. I talk a little bit of, I describe myself as an exercise scientist, but I'm really interested in people's functioning. How they move, how they exert physically to function, and that function can be as simple as fidgeting in your chair, or sitting up, or rolling in bed. And I really think that people who in the severe to very severe range have lost the ability to adapt that you mentioned, and because everything is now in anaerobic pursuit. So the problem with our data set is that we didn't collect enough from the severe to very severe range. We kind of have a lot from moderate to severe, which is more impaired, I think, than we've seen in samples in other studies in the literature to date. But at the two ends, the very mild, where the commenter believes that maybe there's a little bit more flexibility to kind of go up and down with lactate, which could be true, and then at the other end of the tail, the severe to very severe. Folks, we had few of those, and so we tend to be shifted more towards the moderate to severe and severe end, but didn't get quite enough observations to be able to really test that. So it's worth taking a look at that for sure. But my suspicion is that you still would see very high lactate levels in severe and very severe, just because you just lost the plasticity in the system to be able to go up and down, and all you have is anaerobiosis.
Todd, what does the term slow rolling PEM?
So slow rolling PEM is, at least I've heard it described to me. Again, I'm an interloper in this space. I'm a visitor, so I'm very aware of my use of terminology here. I have heard people describe slow rolling PEM as not being post-exertional anymore. It's just all the time. So it's not a push crash cycle. It's not an up and down thing. It's just a flat, everything kind of sucks. It's all symptoms all the time, all functional disablement all the time. And so it's useful. I haven't seen it described in the literature anywhere, and we're going to fix that because I've identified this in a couple of different samples now. So there's just no reason to not talk about this. Where people have just sort of lost the ability to say, yeah, these are things that I do that make my symptoms worse. Like they just lose the ability to be able to say that, or they lose the ability to say, this symptom that I have changes or fluctuates over time. It's just there all the time. And so it's hard because, at least in my own clinical experience, a lot of the folks that I see are in slow rolling PEM. So when I talk about this idea of post-exertional symptoms and signs, they don't identify with post-exertional because it's just there's these things there all the time. And so that when I say slow rolling PEM, that's what I mean.
We have a tracking software, Bearable, right? Our app on a phone. And for one of the side projects, we decided, a few of us, to add PEM on a 1 to 5 scale or 1 to 10 scale. And I had so much trouble because it's the same every day, unless I really, really overdo it.
Yeah.
And then I can tell the difference. But otherwise, there's this slow amount, this normal amount that I just consider my life now. Because I don't wake up refreshed, that kind of thing. So I can't tell the difference. So that's
really good point. Really good point. And so, I mean, I don't have to tell anyone on this call that, post-exertional malaise is an individual phenomenon, that there are things that we identify as being more commonly associated, but there are as many presentations of PEM as there are people with it. Everyone sort of has their own, set of symptoms and signs that kind of fluctuate, that some fluctuate, some don't, some stay around, some change quickly, some change slowly. At Workwell, we've tried to organize them into stages in order to start to make sense out of them based on what we've heard from patients over time. But yeah, that's part of the reason why we collected the data in the manner we collected it. So rather than trying to get to a 0 to 5 or a 1 to 5 scale for PEM, just trying to get an idea of like, what does PEM mean to you? Thinking and just kind of thinking, relatively speaking, if your symptom that changes the slowest, how quickly does it change? And the one that changes the fastest, how quickly does it change? Just to try and give people that flexibility to describe their personal experience. So I just really appreciate that perspective.
Thank you, Todd. All right, we have 2 more questions. Blood test results on my daughter with ME moderate show high triglycerides. Might that be due to poor burning of fats in a broken aerobic energy system?
I think mainly high triglycerides would indicate a level of insulin resistance. I mean, that's our usual kind of default for explaining that. So, and we know that insulin resistance is a big factor for a lot of people with ME. And I don't know what age this person is or what their diet is like or anything like that, but it's probably not necessarily related to their diet. It could be related to their liver function. And so it's probably not a fat issue, is all I'm going to say there.
One of the medications that was used that I take for the hypercoagulability is fenofibrate, and it's for lowering triglycerides and cholesterol. And when you don't tolerate a statin, the Patterson group recommends this fenofibrate, and that worked to me way better than the heparin. It was like heparin on steroids. Now I take both. So I think the triglycerides are something that's, it's one more thing clogging up the blood flow. And if you can do something for that, it might make a difference. I don't know that it's related to my diet or not, but I tended towards high until I went on this med.
And if you think about, sorry, go on.
Oh, no, go ahead.
All I was going to say
a
is
lot with inflammation as well, so that would be. But I'm very curious about the insulin resistance and how those two might actually sort of intersect. If the two of you could talk to that.
Well, all I was going to say as well is, when we kind of live off as much energy as we can, grasp out of our diets, and sometimes taking really easy to absorb meals is better because we can get those macronutrients into your TCA cycle easier. Sometimes that's why the amino acids is helping as well. So if you think of all that glucose, it's even just struggling to get into your cells because your insulin's not working, or your insulin receptors aren't working properly. That's going to be depleting her energy even more.
And just if somebody is inflamed, they tend to be more insulin resistant. And one of the things that over the last few years has been a giant one for me personally has been in training in medical school, you learn of metformin as a diabetes drug, as an anti-glucose drug. But in fact, its action is on something called AMPK that then drives down something called mTOR1, and it's really anti-inflammatory. And by being anti-inflammatory, it increases insulin sensitivity, which then lowers blood sugar. And the interplay between insulin and sugar and inflammation is off the charts. And it seems like the triglycerides go up with more inflammation as well, but I've not dived into that to know that with certainty. Maybe others do.
Well, it's a bit like how, you know, we used to associate blood sugar issues and everything with obesity. And then we kind of learned, well, it's not just like overall obesity, it's your central obesity because it's driving inflammation. So it's not exactly to do with the shape of your body or how much fat cells you're carrying. It's the inflammatory drivers that are coming from those.
All right, thank you. And our last question will be from Veronica. Veronica, you want to come up and ask the question?
Yep, that's great. Thanks. I was just wondering, probably you have done this already, but since there is so much variability between patients, would it be worth more concentrating on the difference and the variability within the, you know, like looking at the trend of each single patient and looking how much that goes up and down, more than setting limits for everybody? Although probably those limits might come within different groups of severity. I don't know if I made that too complicated.
No, I don't think so. And the question's well taken. I think you know, just as the experience of post-exertional malaise is different between patients, it's important to look at individual trends. You know, and of course, one of the limitations of inferential statistics is you're basically collapsing everything into comparing what happens in the middle on the average patient. But what's the average patient who has these conditions? And they're just, you know, this is we're doing research kind of in the tails of that bell-shaped distribution. So I'm totally sensitive to the fact that we probably will need to do some plots in terms of showing individual change. And you know, for 300 observations, it'll be impressive looking, and I'm sure that a journal reviewer is going to look at that like, why are you even spending the time to do this? But you know, in this space, it's important. So I hear the comment, and we're doing it.
And it's really important in looking at studies to say, you know, who are the responders? So you could have a study where on average there's not a difference, but you have a pile or a subgroup of responders that are really affected in a positive way. And one of the concrete things that kind of drives it home for me is if you take 100 people and you put 50 of them on a bike and 50 of them walking, everybody's has an average of one wheel they're using, and it's wrong for 100% of the people.
Good point. Love the analogy.
Yeah. Thank you, guys. All right, we're going to end it here. Thank you, everyone, for attending. And of course, thank you to our panelists today for this amazing presentation. Thank you for all you do for the community. And as always, stay tuned to our upcoming roundtables. And this will be posted to our YouTube channel as well as soon as ready. Thank you, everyone, and have an amazing rest of your day. Bye-bye.
Thank you.